everyone, and welcome to today's Talking Point presentation. I'd like to begin by acknowledging the traditional owners of the lands on which we're meeting today. For me, that's the Bunurong people of the Kulin Nation. I want to pay my respects to their elders past, present, and emerging. Also extending that respect to Aboriginal and Torres Strait Islander peoples who are listening in today or in the future. We recognise and value the knowledge and wisdom of people lived and living experience of addiction and their families and supporters. We also celebrate the strength and resilience in facing the challenges associated with recovery and value their important role in the development and delivery of health and community services. My name is Shalini Aranagiri. I'm the Clinical Director of Turning Point Statewide Services at the Hamilton Centre. And it's my pleasure today to be facilitating Talking Point for this session. Today's session is called Young Men's Anxiety, the Blind Spot in Men's Mental Health and Why It Matters. I'll be presented today by Krista Fisher, who's a PhD candidate at Orygen Centre for Youth Mental Health at the University of Melbourne. Talking Point's a regular series of publicly available lectures that aim to inspire, inform, and challenge our notions of what we know about addiction and its impact across society. We like our webinars to be interactive as possible, so please ask questions via the Q&A function. We'll have some time at the end to go through those questions at the end of the presentation. Our webinars are recorded and they'll soon be made available on the Turning Point website. All registrants will have access to that. Krista's PowerPoint today will be emailed to you after today's presentation, along with some of her recent papers and access to a video abstract of her talk as well. So without further ado, I'd like to introduce today's presenter, Krista Fisher. Krista is a PhD candidate at Orygen and the University of Melbourne, and her work is funded by the Men in Mind Scholarship through the global men's health charity Movember. Krista's research is primarily focused on men's anxiety and its association with other deleterious mental health conditions, including depression, substance use, and suicide. Krista's PhD study, the Men's Anxiety Project, has developed the first theoretical model of men's anxiety, resisting, reckoning, and responding, which improves the identification, assessment, and treatment of anxiety in men. Krista is also working with the National Addiction and Mental Health Surveillance Unit here at Turning Point, NAMSU, to translate those findings into an acute emergency setting. Using data obtained from the Victorian arm of NAMSU and the Australian National Ambulance Surveillance System, Krista is evaluating the clinical characteristics and context of young men's anxiety-related ambulance attendances. Krista is really passionate about improving men's mental health outcomes across the lifespan and empowering men's social networks, which plays a critical outcome and role in mental health recovery. So now I'd like to hand over to Krista to start us off.
Lovely. Thank you. Thank you to Shalini for chairing the meeting today and for the incredible work that Turning Point have done to set up this presentation, and also for the invitation to be here today. I'm really honoured to be the talking point this month, and I hope that you'll find some of the information that I have to share with you really interesting. And I really welcome some of the questions that you might have or thoughts around some of the topics that I talk about at the end of the session. So look forward to hearing from you. So one of the most common questions that I get asked when I talk about my research and some of the work that I do and am so passionate about is why men's anxiety. And I think now that I'm coming towards the end of my PhD and have the 3 and a bit years of hindsight, I can look back and kind of see how this topic really kind of took shape, and why I guess the studies that I did kind of came to be, and how they I guess manifested. But really, I think it started from noticing a real gap in men's mental health research, clinical care, and also some of the resources and interventions that we have at the moment around men's anxiety. So often a lot of the conversations that we were having about men's mental health centered on depression or suicide prevention, all incredibly important topics. But I didn't see really anything or kind of any information and empirical evidence that we had in this space around men's anxiety. And what was really interesting to me was to realize that anxiety disorders are actually the most common mental health condition experienced by men globally. Yet when we contrast males' prevalence rates of anxiety disorders to the prevalence rates of females, we see a big discrepancy here. Males are half as likely to be diagnosed with an anxiety disorder relative to females, and that's worldwide. And where we really see those sex-based prevalence rates start to blow out is in our youth population. So young men aged 15 to 34 years of age. And so before I started my research in this area, other researchers had considered what might underlie these sex-based differences from a biological, neurological, and hormonal perspective. So looking at things like brain structures or differences in hormonal reactivity that might predispose or increase the risks of females to develop an anxiety disorder across their lifetime. But what we hadn't considered as much is the role of gender socialization here. So meaning the ways that we socialize men and women in Western cultures in particular to embody gendered norms or expectations. And so for men, traditionally, we've socialized men in ways that reify and kind of impart the importance of norms like emotional restrictiveness, strength, toughness, stoicism, independence. And whilst these are certainly changing, and in contemporary societies now, we see many different kind of manifestations of masculinities and celebrations of different forms of masculinities, there is still a traditional kind of embodiment that is continued. And what we have seen in past research is that an adherence or and attempts to uphold these traditional norms of masculinity can have significant impacts in men's health outcomes, both physical and mental health outcomes, including things like increase in risk-taking behaviours, as well as a reluctance to seek help or opting to kind of instead be self-reliant rather than accessing health services that are available to them. And so when we consider the state of men's mental health more broadly in Australia, we can see some pretty startling and worrying statistics here. And it's clear that a lot of young men in Australia are dying too young. Around about 3/4 of all suicide fatality rates are males. And this is quite startling when we kind of consider that some of the psychiatric disorders that we know might predispose suicide behaviours and fatalities, things like depression and anxiety, are a lot less likely to be diagnosed in men. So we have this real disjunction between our identification of psychiatric issues and illnesses and the kind of unfortunate suicide fatalities that we're seeing here. And so around about 6 suicides every day are men in Australia. And suicide is the leading cause of death in young men aged 15 to 44 years of age in Australia. And we do see similar rates across other Western countries, including UK and the US. And a lot of kind of the background rhetoric that surrounds men's suicide is that there's a lack of help seeking there, that men might only be accessing help at really crisis or severe kind of situations of psychological distress or suicide. But more recently, what we've realised is that there's some statistics that challenge that notion. And actually, in one study, I think that this was published in 2019, but the researchers found that 60% of all men who had died by suicide in 1 year had actually accessed mental health support in the year prior to their death. So it's not just around a lack of help seeking, it's also concerns around continual engagement in mental health services. So whilst, yes, we do need to focus on getting men through the door of mental health services, there's also bigger issues here around ongoing engagement and how we can better kind of continually make sure that men are accessing care when they need it. And why men's anxiety matters here is that more recently, too, we've seen some real strong evidence that shows that anxiety is a unique risk factor for later suicide ideation, behaviours, and fatalities. And so when we're thinking about men's increased risk of suicide, anxiety kind of plays a critical role that we haven't looked at, and I think we need to look at. It has also been termed a gateway disorder, meaning that often what we see is anxiety disorders in boyhood being the first kind of mental health condition that manifests before any later comorbid mental health issues. And an important factor and unique factor around anxiety is that it's both an emotion as well as a mental health condition, a diagnosable mental health condition. And what we know and need to keep in mind is that it exists on a spectrum. Anxiety can certainly be very adaptive and important in a lot of situations. It helps us identify fear or, potentially threatening situations and act accordingly. But where it starts to reach the threshold of more of a psychiatric or pathologized mental health condition is when it starts to impact social, occupational, and vocational functioning. And usually that's determined by a mental health clinician according to current diagnostic criteria that we have in the DSM or ICD 11, for example. But I think that this a video put together by Glamour magazine, which is a big magazine in America, really kind of reinforces this point quite well, I think, where they developed a video and they shared a video back in 2020 where they asked boys from 4, I think, to 80 years old what makes them anxious. And just in some of these responses, you can see how those anxiety triggers and even stressful life stresses change across the life course. And I think what this really emphasizes as well is that the importance of taking a within men approach here when we're understanding and looking to better understand the experience of anxiety. How anxiety manifests and some of those anxiety triggers are going to be very different for boys and adolescent men relative to adult or older men, and how this might change over the lifetime. So once I was getting my head around, I guess, what had been done and what we did know about men's anxiety to date, before I kind of determined what studies would determine would be part of my PhD project, I wanted to start off with a systematic review. This was the first systematic review in the field of men's anxiety. And what this did was have a look at all of the research that had been done in this area, which included qualitative and quantitative based work. So looking at data sets and numerical data relative to speaking to people and gaining qualitative data from those interviews, and understanding 4 aspects of men's anxiety. So this review was really focused in on what do we know about men's experiences of anxiety, how they cope with anxiety when it arises, their attitudes and behaviours towards help seeking, and also whether there was and what the role was of masculinity in men's experiences. And so we found some pretty interesting and important things here. Firstly, that there was early evidence for a male type phenotype of anxiety. And what this really means is that there were some unique patterns in the ways in which anxiety symptoms were manifesting for men. The work that had been done in the area at the time really was looking at men's anxiety symptoms relative to the types of symptoms that we might be seeing in females. And they did this by using anxiety surveys or measures, things like the GAD or even the DAS, which is another depression, anxiety, and stress scale, or diagnostic clinical interviews. to have a look at different types of symptoms that were manifesting in men, which included things like increase of physical or psychosomatic symptoms. So maybe symptoms including headaches, body aches and pains, nausea, things like that. So a lot of physical distress and uncomfort relative to females, where we were seeing more kind of concerns around their social worlds or interpersonal relationships. And what we were also seeing was high levels of guilt and shame that men were reporting, which coincided with their anxiety experiences. Now, in terms of coping strategies too, men were more likely to report or revert to problem-based coping, looking or attempting to find solutions as a way to minimize the anxiety symptoms that they were experiencing. Whereas what we were seeing for women and females was looking for more emotion-based support through their social supports and worlds. So looking for ways to minimize the emotional distress that often accompanied anxiety disorders and symptoms. Now, help-seeking attitudes and behaviours, that actually made up the bulk of men's anxiety scholarship at the time. So for this particular component of the review, we were able to take a bit more of a within men focus. So there were some findings which were distinct to young men here, being that young men in particular were more likely to revert to self-reliance or seeking help through informal supports, their friends and family, rather than going to access support through formal mental health services. And a lot of the reasons that they gave for this was concerns around fear of judgment from their peers or family members, even concerns around confidentiality, so not understanding, I guess, the bounds of clinician and client interaction. But also, I think this was kind of critical, was a lack of understanding about what anxiety disorders were or the help-seeking options available to them. And lastly, what was clear was that there was a big role of masculinities here in men's anxiety, largely that young men themselves perceived a real juxtaposition between some of the norms that they felt should accompany their gender or that were kind of key pillars of their masculine identity, and the experience and expression of anxiety. And this wasn't just men themselves reporting that kind of cost to their masculinity. What we also saw was broader social ideals around this as well. So I think a good example to explain this is one study where they gave male and female participants in their study vignettes of a man with anxiety and one without. And collectively, when they asked the participants to kind of rate or reflect on their vignette's masculinity, the vignette without anxiety was kind of deemed to be a better representation of traditional masculinity. So the participants rated that vignette as more masculine. And importantly, what we saw here was a bit of a cycle taking place where when there was this perceived sense of failure or guilt, shame even that young men might be experiencing with respect to a perceived cost to masculinity, anxiety symptoms only increase, and this kind of increased the issues that they were experiencing around that shame, which then exacerbated the anxiety and perceived cost to their masculinity. So these three components really interplayed and exacerbated anxiety symptoms for men. And what was also clear from the review, and kind of one of the key takeaways for me in terms of future directions for the field, was that there was a real lack of research which had actually spoken to men themselves garnered insights around men's experiences from hearing from men what it was like for them. How did anxiety manifest? What did it feel like? And how does it change over time? And there was also no research that had, or qualitative research specifically, which had spoken to young men themselves. So to me, this seemed like a critical area for future research and what we needed to know more about. Because to date, the field was then relying on a lot of assumptions gained from big quantitative research, which was important, but hadn't distilled the nuance surrounding men's gendered experiences here. And so for this study, what I chose to do was undertake a grounded theory study. And what this means, what grounded theory is being able to develop a theory of an under-researched phenomenon, which in this case was men's anxiety, from the ground up. So you interview participants, and the insights that you gain from these participants then is used as the backbone to be able to build or develop a theory for what's going on. So in our study, we had 25 participants in the young man age group, so 15 to 25. The mean age of our participants was 22 years. And as we can see here, there was a relatively good diversity, ethnic diversity in our sample too, which is really important. And most reported severe anxiety based on an OASIS scale. We didn't want to limit our sample to only men who had sought help before, so that wasn't an eligibility criteria. We had 20% of our sample who had never sought formal mental health support before, which was, critical for our understanding of anxiety. We wanted to have a good representation here of different clinical exposure. And so the theory that came from this study was titled Resisting, Reckoning, Responding. And what this shows is the phases through which young men come to understand, gain awareness, and then start to respond to their anxiety experiences. And firstly, in this resisting phase, what often was described by young men was initially that anxiety symptoms started to manifest as something physical. So they described it as uncomfortable or kind of concerning physical symptoms, but they in no way kind of associated that with anxiety at the start. So they were distressing and uncomfortable. And when they, arose for young men, how they responded to that at the time was wanting to avoid or dismiss those symptoms. So there wasn't any kind of awareness or tying that to anxiety at the time, but it was something uncomfortable something to be avoided. So we have our participant Luke here, who describes this in a really great way, when he says, "I think it's been around a lot longer than I've been able to identify it," meaning his anxiety. "I didn't really have a term for it at the time, but I just didn't really think about it." But then what we saw for a lot of young men was that as that avoidance tendency started to increase, it wasn't, there were bounds to that sense of avoidance. So things like social withdrawal, so wanting to remove themselves from social situations if those symptoms were arising, they stopped becoming effective as the anxiety symptoms started to increase and come about in more and more situations, which we termed a diffusal or a diffusion of anxiety, So an example of this was a participant was saying to me that he started to notice those more physical symptoms initially when he was doing exams at school or presenting in front of a class. But then what happened is over time, those same symptoms started to arise in sporting games on the weekend when they had never, previously elicited those kinds of symptoms. And then all of a sudden to a social gathering on the weekend. And so as this diffusion started to take place and the symptoms were arising in more and more situations, it forced the young men often to start to question what was going on here. And this process we termed meaning making, but it was really a process of introspective and retrospective meaning making, starting to garner or gain literacy and language for these anxiety experiences, to start to understand what was actually happening to them. So our participant Nick here says, it wasn't until I had a full emotional response that I could even acknowledge that it was that bad. It just didn't make sense. It was quite scary. And just thinking about what caused it, it was nothing and everything at the same time. So that was really confronting. And as young men started to gain more understanding and awareness of their anxiety and start to build that literacy and language within themselves, some then talked about reaching a place of acceptance where they started to integrate anxiety as a part of their broader masculine identity. So an example of this is kind of reframing some of those norms that maybe they had held of themselves. So an idea of what, for example, courage is, reframing that to fit their anxiety experiences. And at this time, often that acceptance of anxiety within themselves also meant that they were more open to and accepting of different help-seeking options available to them, which included both talking to their friends and family about anxiety, but also maybe reaching out to formal mental health services in times where they might have needed more support. And at this phase, often the young men also spoke about starting to develop more coping strategies or tools to cope with anxiety when it arose. And examples of this for a lot of young men, they talked about journaling or meditation, even just the benefits of exercise and being out in nature or interacting with other people, even if they weren't necessarily talking about their anxiety. But important here to note that this responding phase was cyclical. And what this meant was that in situations where perhaps the anxiety symptoms were so overwhelming or so overbearing that young men felt that their coping threshold had been exceeded, some spoke of reverting back into more avoidance-based coping strategies. So even things like increased substance use. And then I guess the process kind of started again. And Sean here talks about how I agree, or he says that I agree that you have to be tough in life and you have to get up and all those kinds of things. But part of that is just being brutally honest and open about how you're feeling. So I think really being a man or being a tough person is just about being straight to the point, being blunt and not hiding anything. So it shows that real process of reframing that often takes place in that responding phase here. And so some of the takeaways from this finding, from this study, were really what we need to do from an early intervention and prevention point of view to both release young men that might be locked in some of those phases or processes, and how we can think about better supporting men with anxiety from a clinical research and broader public health perspective. So I think that was critical, or it was clear from the results that we need to disrupt that over-normalization that often takes place around anxiety. So the dismissal of anxiety as something that can be really serious and debilitating is important here, because often it took young men a long time to start to realize the seriousness of anxiety in themselves. But also the importance of better psychoeducation here that really taps into the gendered elements and gendered nature of anxiety for young men, which allows them to start to understand their own experiences a bit better and make sure that what they're experiencing actually fits within our broader conceptualization of anxiety. And lastly, just tapping into the importance of acceptance-based practices. These did seem really effective for a lot of the young men that we spoke to here. And so at this time, when I was wrapping up the write-up of this study and thinking through some of these findings and I guess where to next, I came across a report that had been published and undertaken by the team at Turning Point, which was using some of the data from the National Ambulance Surveillance System, which I'll talk through in the next few slides, to explore men's mental health-related ambulance attendances. And what really got me with this report and what I found quite interesting was that anxiety-related ambulance attendances were the primary reason for men's mental health-related ambulance presentations. So as I was thinking through these findings and starting to think about, well, what's next? Now we understand men's experiences. I guess the secondary part to that is when and where are they coming into contact with health services? Is it that they have to, get through years sometimes of self kind of discovery and self-understanding and awareness to then only access care in the responding phase? Or are young men who might be still in this resisting phase, not necessarily understanding anxiety, but requiring more support, are they potentially reaching out through different avenues like our emergency medical systems? So that kind of framed, I guess, this next component and pathway where my PhD led. So the National Ambulance Surveillance System, it's run through Turning Point and Monash University, and it collates all of our ambulance data from paramedic records across most ambulance services in Australia, relating to suicide and self-harm, mental health-related ambulance attendances, but also alcohol and drug use related presentations here as well. So the team had done some really great work in mapping some population-based trends in different areas of mental health and AOD population-based health outcomes. But I really saw an opportunity here to be able to bring qualitative methodologies to this data to elevate and hone in on young men's individual experiences by looking at all of the individual paramedic records to understand men's anxiety presentations a bit better. And this was a 4-phase study using, as I mentioned, qualitative methodologies, but also quantitative methodologies to be able to harness the big data and the numerous amounts of data that were available through the National Ambulance Surveillance System. And there were 2 aims of this study here. I wanted to understand what the clinical characteristics were of young men's anxiety presentations, but also the context in which they actually reached out for support and what was going on at the time of these paramedic attendances. And for our sample, as I mentioned, there was quite a lot of data that was available to us. But I wanted to hone in on that young male-specific subpopulation. So I limited our sample to the Victorian arm of the National Ambulance Surveillance System, looking at young men, so aged 15 to 25 years of age, with an anxiety-related ambulance attendance in 2019 to avoid any bias that we might see with some of the COVID lockdowns and regulations that kind of took over from 2020. So this left us with 696 young men who presented to a Victorian ambulance service in this time. And looking at the demographic variables and characteristics of our sample, the mean age was 20.56 years. Most of the young guys resided in a metropolitan area. And also most 61% reported a history of anxiety to the paramedic in the attendance. Also interesting that 33% of the young men in our sample were not transported to hospital, with the primary reason being that treatment and transport was not required after the paramedic had arrived. And so the 4 phases, what that involved was firstly developing a coding framework through which we could start to understand those and interpret the paramedic case notes, then test that coding framework. And that used both qualitative and quantitative methodologies here. And then start to interpret and look for different typologies in the types of presentations that we were seeing. And the first research question was wanting to understand what the anxiety presentations look like, how the anxiety presentations were kind of being described by the paramedics in their case notes. And this visualization shows a macrophenotype of the non-discrete clinical characteristics that we were seeing. So what this meant was that, for example, psychosomatic symptoms may have been present alongside involvement of alcohol and drug use. So it wasn't just that one thing was coded for each of the young men who presented. And so what we commonly saw was a lot of psychosomatic symptoms here. And this ties in with some of the past findings in some of the past research that I'd done. But psychosomatic symptoms here included things like body tremors, nausea, even through to more severe ends, things like fainting, seizures, loss of consciousness. So there was a lot of that reported here by young men. But also, as I mentioned, involvement of drug and alcohol use, and a description of broader social stresses or situational stresses that were going on in the young men's lives that they felt like had kind of led or exacerbated the anxiety that they were experiencing. And once those clinical characteristics had been better understood, I then used a methodology called hierarchical cluster analysis to be able to split the young men into groups based on similarities in the ways that these clinical presentations tended to present together. So were there similar kinds of presentations that we were seeing across our sample? That was what I was really looking for here. And then once I had split the young men into different types of groups based on these presentations, I then explored these presentations in more depth, interpreting the typologies. And so when I started to look at what the broader context of these anxiety presentations were for the young men, I could see that there was a lot of described physical pain here, as well as a lot of uncertainty. So not really knowing what was going on, and often a psychological crisis that had then led them to call that 000 operator and reach out for the emergency support. And this heat map starts to show a visualization of the typologies that we identified. And this shows the ways, the patterns of the clinical characteristic coding framework that I developed initially, how those codes manifested across the different typologies. So, for example, young men in our termed psychosomatic anxiety group, all of them in this group had psychosomatic symptoms coded in their anxiety presentations. And this will make a little bit more detail in the next few slides. So the first typology, as I mentioned, psychosomatic anxiety, the young men in this group, they tended to have more of a sudden onset of severe psychosomatic anxiety symptoms. There was a lot of uncertainty around this, and there was often fear around these symptoms. So concerns that what the young men might be experiencing was a physical kind of health condition or even potentially life-threatening. Whereas for our second group, which we called the anxious substance use group, these anxiety presentations were often coupled more with alcohol and substance use, which had either precipitated or perpetuated the anxiety presentation. So meaning that for some young men, maybe their anxiety symptoms had only kind of occurred following recent drug or alcohol use, or for others, they, described alcohol and drug use as a way to cope with anxiety that for some had been building up over days, weeks, months. And often these presentations also encompass behavioural changes, which included agitation, aggression, and occasionally violence. For our last group, our complex anxiety group, these presentations were often more of a significant deterioration in broader mental health outcomes, including things like self-harm behaviours, suicide ideation or behaviours. And often for young men in this group, their anxiety presentations were kind of amplified by the social and situational stresses that were going on in their lives, which made ongoing engagement in psychological treatment and services difficult. So in the next few slides, I'll just present some dummy or vignette cases of paramedic case notes, so kind of giving you a bit of an idea of the type of data that I was able to go through and look at for each of the typologies. These cases were kind of an amalgamation of the types of presentations that we were seeing in each typology. So here we have Adam, who's a 20-year-old man, and he was driving home from work today when he had a sudden onset of shortness of breath, followed by chest tightness and discomfort. Adam pulled over to get some air and then reported bilateral tingling and numbness in his arms and legs. Adam's shortness of breath progressed to hyperventilation, stating to paramedics that he was having a heart attack. Adam flagged down a bystander who called 000, and on attendance, Adam was very distressed and emotional. The vital signs were normal, indicating no cardiac abnormalities, and reassurance was provided to Adam by the paramedics, and he was transported to hospital. Whereas for the anxious substance use group, we now have Cam, who is a 15-year-old male, and he became increasingly anxious and agitated after consuming half a bottle of vodka in the last 8 hours. Cam's housemate at the scene called 000 when he was unable to calm him down. According to housemates, Cam had also consumed ice, cocaine, and benzodiazepines over the last 5 days with no sleep. When paramedics arrived, Cam was extremely anxious, hyperventilating and grabbing his chest, stating that he wanted to go straight to hospital. Cam appeared distressed and teary, but anxiety reduced following reassurance. And lastly, in our complex anxiety group, here we have Daniel, who is a 21-year-old male, and he states that he's suffered with poor mental health for the last 18 months with no diagnosis. He's currently waiting for an appointment with his psychologist. Daniel's mum reports that he's been increasingly withdrawn and anxious over the last 4 days, which Daniel states is due to his partner relocating for work and significant financial strain. Tonight, this escalated into a verbal confrontation with family members, and Daniel stated that he just wants it all to be over. Daniel stated to paramedics that he was aware he needs help, but doesn't know what to do. Daniel was transported to hospital for appropriate mental health assistance. And so, leaving the biggest question for last, where to from here? It's clear that, I guess, a response to ultimately reduce the amount of anxiety presentations that we're seeing to emergency services isn't straightforward. And really, I think needs to be tackled from a range of different avenues, including improved research, also potential policy changes, and clinical and treatment care improvements for the ways in which we're addressing men's anxiety and specifically young men. But I guess some three, I think, broad avenues in which we really need to focus our attention is being better able to identify anxiety at the time in which young men are actually operators, which is really difficult given when often some of the symptoms that young men were describing closely mimicked that of what we might see in a cardiac or respiratory related life-threatening condition, which often does elicit, an immediate emergency response. But also, I think another avenue that's quite critical is improving the ways in which or the resources available to paramedics to actually respond to young men at the times in which they're at this ambulance attendance. Because often the procedures that they have are quite limited. When we think about the ways in which emergency medicine and paramedicine, really, the role that they play, anxiety sits quite different to that because it requires a lot of reassurance and support, which, knowing the overwhelming burden and demand already placed on our emergency systems, paramedics just aren't best placed to do this. So I think if we can develop certain resources or a kind of online e-intervention that could be delivered and disseminated to young men, that could be really helpful at this kind of critical juncture here. But also, I think, lastly, to understand what's happening in terms of longitudinal outcomes in men's health, ongoing health service engagement following that ambulance attendance. So again, I think anxiety is unique here in the way that even though often a lot of the symptoms or experiences that young men are having here, they are very debilitating and a lot of the time seen just as real as any other physical condition for men. Anxiety doesn't necessarily or doesn't normally meet the threshold for triage onto emergency mental health services, which we can assume means that a lot of men do fall through the cracks, even if they are transported to hospital. So understanding those patterns of health service engagement and whether young men particularly are representing to ambulance services over time will be really interesting. So an example, as I mentioned, of I think a critical resource or intervention that we could develop here is broadening out already existing men's health psychoeducation resources, such as something that my colleagues in Vancouver have developed called Heads Up Guys, to also encompass information and support for men with anxiety. At the moment, this is just limited to depression and suicide. So I really want to be able to build that out to also have content on anxiety, so that paramedics might be able to give that to the young man at an ambulance attendance if there's low literacy or understanding around anxiety. So to wrap up, I just want to say a huge thank you to not only the Turning Point team, who have been so supportive and welcoming with my work with the ambulance data, but also to my other PhD supervisors. And I welcome any questions that you might have, if you can put it in the Q&A and chat box.
Brilliant. Thank you so much, Krista, for a great flyover of a tremendous amount of work that you've done over the last few years, and some really great range of different methodologies that you've used to kind of get a really in-depth kind of understanding, I think, of this area. There have been some questions that have popped up, and really encourage people to pop any other questions you've got in the Q&A box now. Got a little bit of time to cover that off. I think one of the questions that came up a bit earlier on in the presentation, Krista, was around some of your methodology with the qualitative study in particular. And one of the questions was around ascertainment with that sample. So what the source was for the young men that you spoke to in the qualitative sample. If you could speak a little bit more to that, that would be great.
Yeah, absolutely. So for the grounded theory study, as I think I mentioned, I wanted to be able to recruit men who both had and hadn't sought help for anxiety before. So my PhD through University of Melbourne, I'm situated at Orygen, which is a youth mental health centre there. So we partner with some headspace centres in northwest Melbourne. So I was able to recruit young men who from a clinical sample through headspace centres. But I also shared the study quite widely on social media. So not only Orygen's platform, but also using some of the University of Melbourne student forums there too. And so the reach through social media meant that I was able to access men to participate in the study who, weren't already linked into headspace centres or Orygen.
A really wide sample there. It's really interesting. And I think another topic that's a theme that came up, I think, in some of the questions is around that aspect of sort of masculinity that you were tapping into, and some questions around what that relates to, whether that can be a positive aspect as well or a protective aspect.
Yeah. And it's something I think that we need to think about as we're being able to better measure and conceptualize more contemporary masculinities as well, because the only real way that we have of measuring masculinity at the moment is reverting to those traditional masculine ideals, but it's certainly changing. And I think that in some ways, particularly for anxiety, things like opting for toughness or the importance of strength, fearlessness can actually be, adaptive to a sense with anxiety. So being able to leverage that to handle or cope with anxiety in a positive way, in an adaptive way, not in a way of avoiding the symptoms or trying to deny those symptoms when they arise, but actually being able to harness a broad range of support, both independent and through friends and family or more formal mental health services, is really important here. So I think it's something that we need to look into in the future. But yeah, certainly there is some promise that it can be positive as well.
And a little bit related to that, one of the questions that came through in the Q&A was around, through your understanding of men's experiences of anxiety through all of these studies, really, what's your understanding about, I guess, how that information can help inform clinicians across their mental health and drug and alcohol sectors, particularly around this question's arisen around the use of violence potentially. So in terms of intimate partners and family violence, do you think it has any role to play there as well?
I think probably the biggest thing from a clinical perspective is thinking through ways that we can identify anxiety early on. which can be difficult if we're not seeing men come into contact with clinical services until some of these, I guess, more harmful or deleterious mental health stages of their mental health. But I think being able to understand different manifestations of anxiety is really important, and hopefully something that my research can start to do, broadening out what anxiety looks like in men beyond just what we might see in our current diagnostic criteria. So something like understanding that anxiety can potentially manifest as aggression and violence in or for some men is important, I think, because otherwise we might miss it. And also starting to bring in conversations around those masculine ideals with men in clinical settings, in treatment, starting to challenge some of those notions can be really effective to then start to get to the underlying anxiety issues and start to handle it head on.
It's a really rich area for kind of more work, as you're saying, kind of understanding how that can play a role in practice. I think some of the other reflections that are coming through in relation probably to the latter stages of your PhD around the emergency and acute kind of settings, which is a really great example of kind of that collaboration between Orygen and Turning Point around that data set. And so I think one of the questions that was coming up was around a reflection on ambulance settings and how acute that presentation can be, but then what happens afterwards. And, I suppose for a lot of people, discharge might occur without necessarily much in terms of continuous care or follow-up. I wondered from your perspective of having done all of this work, what your thoughts are around that discharge for, what would likely be ideal to happen at discharge, but also I guess your thoughts around what interventions could look like, that next stage of research for you potentially, what that would look like.
Yeah, and the nature of, I guess, the paramedic notes is that we get a snapshot of the ambulance attendants, but we don't really know from just the ambulance notes itself what happens following transportation to hospital. So we're able to delineate whether a young guy was transported or not, but not what happens after, which I think will certainly be something that we can look at in the future using data linkage with other data sets and information to see those pathways once transportation maybe had occurred. But I think it's pretty safe to assume that based on triage guidelines as well, the Australasian triage guidelines, that anxiety often doesn't meet that criteria unless there's other things present, like in our complex anxiety typology. If there is self-harm and suicide behaviours, then that's probably a different the triage response to that might be quite different. But based on our understanding in the literature around emergency medicine for anxiety presentations, there may be a consultation with a psychiatrist if they're available, or otherwise it's a prescription of some kind of anti-anxiety medication. And really those settings, just based on the overwhelming demand already placed on them, there's no way to be able to better deliver education and support to young men in those settings. So I think we need to think about ways that we can do that and leave them with something beyond just relying on the clinician to deliver that kind of information, which is great because we have these online sources of information that we can build out and deliver now. But making sure that it's not just a discharge and then they fall through the cracks and never see anyone again, which can perpetuate those, sensations of shame and embarrassment. Well, it's not that serious. I shouldn't have called, an ambulance or a paramedic. So we want to avoid that and look at ways where we can give that information and support to young men through different modes and means.
Fabulous. It sounds like there's a bit more work to be done there. And I guess as a final note, did you have any comments or thoughts about future research in this area, work that you'd really love to do?
Yeah, I think I would really love to start thinking two projects that I really want to focus on is some kind of data linkage study. So understanding, as I think I've touched on, what happens when men with anxiety do present to ambulance services once they are transported to hospital, what those longer term trends look like. That's something that I'd be really interested in. And then looking at whether there are differences in the three typologies of those pathways in health services. And also, I want to look at being able to build out those anxiety-related psychoeducation resources for young men specifically, so that we have something tangible that we can give them, and then be able to measure the effectiveness and uptake of those resources.
So there are no further questions. I think we probably will end there at 2 o'clock. Just some lovely comments coming through and some feedback that they've really appreciated your talk and all your work, Krista. So thank you for joining us, and thank you to all the attendees for joining us for today's talking point. Have a lovely day.
Thank you very much.